I welcome all delegates, faculty, and the ambassadors for this webinar, for this international webinar. I bring warm greetings from American College of Gastroenterology as the Governor of India region and as a member of Scientific Committee of the World Gastroenterology Organization. I bring warm greetings from WGO and from Tamil Nadu Dr. MGR Medical University and Medindia Hospitals and Academy and various other organizations have that. This webinar we have the experience of having conducted earlier during the pandemic period. We had over 9,000 delegates from all over the world. That really inspired us when I took over as the ACG Governor India region. Why not we do this? This webinar series meeting 2 is accredited by Tamil Nadu Medical Council and endorsed by American College of Gastroenterology and organized by Medindia Hospital Academy, which are affiliated to the Tamil Nadu Dr. MGR Medical University. And today's topic is on the most important and very interesting at the same time the medical and surgical emergency is acute severe pancreatitis. And I'm very glad to tell you that 2,684 as and now they have registered for this this webinar, and I have my pleasant duty to introduce the faculty. You see this, we have two eminent speakers who have really done the original work in this field. Our webinar has been designed in such a way that one from the USA, one from the Indian, the eminent Indian faculty and moderated by our equally eminent faculty also there. And going to Dr. Pramod Garg, who has done very important work and original work in the field of acute pancreatitis. I've been associated, I've known him for the last 2-3 decades. He is a professor of gastroenterology and associate dean research, All India Institute of Medical Sciences, New Delhi. He is published over several seminal papers and associated editor of International Journal Pancreatology. He is the secretary of the International Association of Pancreatology, is a member project review committees of Department of Biotechnology and Department of Science and Technology. He is the recipient of Basanti Devi Amirchand Award, the prestigious award from Indian Council of Medical Research. And we can't get a better person than him to talk on acute severe pancreatitis, the first week, what is happening there. And we have the second speaker, Professor Dr. Vivek Kaul. And his claims also the Secretary General of World Gastroenterology Organization, is a member ACG GI on Demand Task Force, is the chair of the ACG Innovation and Technology Committee. I really like that the kind of committee they have in ACG, and the chair of the World Gastroenterology Organization Endoscopy Committee, and he is a professor of gastroenterology and hepatology at University of Rochester Medical Center, Rochester, USA. Okay. And to chair the moderate this session, I have my good friend Dr. C.C. Chaubal. He is the senior most gastroenterologist from Madhya Pradesh and Chhattisgarh. He is the founder president of MP and CC chapter of Indian Society of Gastroenterology and governing council member of SGI. And he had very outstanding academic career. I have known him since my the fellowship days. And Dr. Pravir Roy is young, eminent, and he's shown keen interest in pancreatology and endo-ultrasonography. He is a professor, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, UP, India, and a member Asian US Study Group, author of over 120 publications, and is joint secretary of Society of GI Endoscopy of India. And he is in the editorial board member for the Journal of Digestive Endoscopy. Having said about this webinar would not have been possible with the cooperation and coordination, hard work rendered by my colleagues, Dr. Gokul, Dr. Satya, Dr. Yogesh, Dr. Prasad, and Dr. TNS. And this message of webinar could be spread widely to various parts of India and rest of outside India because of our national ambassador Chaubal, Pravir Roy, Dr. Ramesh Kumar, Srinivasa Rao, Praveen Kumar, Arvind Gobbi from Karnataka, Girish Kumar from Odisha, Mahapatra of West Bengal. What we have done is we have selected the academically really strong people who could really spend time for spreading this academic information. Dr. Mahapatra from West Bengal and Ashish Agarwal, Nirmal Jit from Punjab, Rajiv from Maharashtra, Venkata Iyer, Sahin Nair from JNK, Lamba from New Delhi and Haryana, and Jayan Ghosh from Jharkhand, and BD Goswami, who is take care of 7 state plus Sikkim, and Ashish Kumar Jha from Bihar, and Arvind Kumar from Uttarakhand, and Devendra Singh from Chhattisgarh. And we have equally eminent international ambassadors, and we could get this figure, people, the number of, I mean, the people who have registered for this number, this level, because of the hard work rendered by this ambassador. And the Tamil Nadu Medical Council has given the credit hours for this. And our academic partner, I see Mr. Jayaraj and Subhendra Tata, and from Micro Labs and the Micro Knowledge Academy there. Now, this first webinar was inaugurated by the president of American College of Gastroenterology, Professor Dr. Jonathan Lighton. He talked on inflammatory bowel disease. After that, this is a second webinar. We have lined up webinars for 12 webinars throughout this year. Every month, last Wednesday, we have a webinar from April to March. The third webinar is going to be geriatric gastroenterology and pediatric gastroenterology. We have one important eminent faculty from USA and our own faculty from Lucknow. And the fourth webinar is going to be biostatistics for doctors. That is a very important, I felt so. And the research output might improve after listening to this lecture. And there is another very important topic, how to write systematic review and meta-analysis by Babu P. Morgan, who has done maximum number. To the best of my knowledge, he is from USA. And the fifth webinar is going to be celiac disease and non-celiac gluten sensitivity. We have Professor Amy from Mayo Clinic, Rochester, and non-celiac Dr. Govind Makaria. And seventh webinar is on Barrett's esophagus. Nicholas Sahin is the world authority on Barrett's esophagus. And GERD by Prasad Iyer, and hepatology, the met and unmet needs by Dr. Shiv Sarin, and MAFFLD and MASH by Ajay Shah. And the other webinar, colonoscopy, the unseen and to be seen, one of the most popular speaker, Douglas Rex from USA, and Dr. Nagesh Reddy, our own colleague, the rate limiting steps, that is ERCP, the met and unmet needs, and fecal microbiota transplant by Professor Neil Stolman. He is the world authority on FMT, and probiotics by our colleague Dr. Ramakrishna, and high quality colonoscopy. This is the need of the hour for our residents by Professor Kostas Kefalis, and high quality upper GI endoscopy by Pratik Sharma, president of American Society of GI Endoscopy. Then we have H. pylori and GI malignancy. You'll be wondering, why did I miss that sixth webinar that is going to be held in September? The pleasant surprise and a very good news. We worked for 3 months for this to get him, is we are going to have in September, 25th of September, Nobel Prize winner, the lecture by Professor Mary G. Marshall. He is the discoverer of Helicobacter pylori, which revolutionized the management of peptic ulcer and stomach cancer. Is an international webinar. To the best of my knowledge, is the first time addressing the large group. We are aiming for 20,000 viewers, and should be attended by all gastroenterologists, all doctors, physicians, surgeons, postgraduate medical students, microbiologists, and pathologists. So we'll spread this message. So we are going to listen to Barry Marshall in September, and we'll send you the detailed program later. And again, the academic partner Microlab is with us. Now, with this introduction, let me hand over the mic and the proceedings to the Dr. C.C. Chaubal, who will start the lecture session now. Chaubal, unmute. Unmute.
Thank you, Dr. Chandrasekhar, and good evening, everybody. It's really extremely hot here in Bhopal, just like we have in Delhi. Now, talking about this particular topic, we all know that acute pancreatitis is one of the major GI emergencies which causes hospitalizations worldwide. The incidence of this problem is also increasing in several countries. Fortunately for us, at least 80% of the times, the disease has a milder course. However, around 20% times the patients have a very severe disease, which is going to be the focus of our talk today. This severe disease has a fairly high mortality varying from 20 to 40%. Important thing is the initial management in first 72 hours after the diagnosis is pivotal and it can influence the clinical course and outcome of the disease. Early identification and the appropriate interventions can prevent complications and improve patient outcomes. Unfortunately, there is no specific pharmacological therapy so far for managing the earlier stage of pancreatitis. However, to improve the outcome, there are several issues which are there in the management during the initial 3 or 4 days, including assessment of disease severity, fluid resuscitation, the pain control, nutritional support, whether to use antibiotics or not, and ERCP in certain subsets of gallstone pancreatitis. I think all these issues are going to be addressed by our very learned faculty, Dr. Pramod Garg, whom I now invite to deliver his talk.
Good evening, and thank you, Dr. Chaubal and Dr. Chancheka, for this kind invitation. I'm really happy that there are so many delegates attending this webinar. And congratulations to you for organizing a large series of webinars on very important topics over the next 1 year. So thank you once again. And my job today is to talk about management of acute pancreatitis in the first week, and subsequently Dr. Kaul will talk about management of patients beyond the first week. So let me first begin by showing you this very important slide where you can see a large collection, perhaps a world of necrosis. And nowadays you can see these patients being treated endoscopically through EUS guided drainage, and a metal stent is often put in. And often what happens is when you see these patients being treated during live workshops, you can see that their patients have undergone an EUS guided drainage with a metal stent here. And often you find that once the pus starts draining out, there is a lot of clapping, right? And people think, and often you do an endoscopic necrosectomy as well. So this is actually touted as a cure for acute pancreatitis. Unfortunately, it is not. And the reason I'm saying that is that what you're treating here is not acute pancreatitis, but a sequelae of acute pancreatitis 4 to 6 weeks down the line, or sometimes even later. Now, I will draw your attention to a disease entity that we all see very commonly, that is sepsis. And there's a reason I'm drawing your attention to sepsis. Sepsis is defined as infection plus organ dysfunction. So infection accompanied by organ dysfunction is sepsis, right? And it is a complex disorder that develops as a dysregulated host response to an infection. Now you just see the words here, dysregulated host response to an infection. So if you have 100 patients coming in with similar infection, for example, pneumonia, you would find that only about 10% or even less will develop organ dysfunction. And to diagnose this, now we have a quick SOFI score, which is very convenient in the emergency room, alteration in mental status, systolic blood pressure of less than 100, and a respiratory rate of more than 22 beats per minute. If you have 2 out of these 3, you know this patient is having sepsis, in addition to infection, which is the cause. Now, it is considered a medical emergency, and we all know that. And there is a surviving sepsis campaign started in 2018, which says if there is hypotension, you give fluids to these patients, 30 ml per kg. They need to be given IV antimicrobials as soon as possible, ideally within an hour of presentation, and with a broad spectrum cover. You should measure lactate and obtain blood culture. Now, this is what we all know as physicians. And I think this is a very important entity that we see day in and day out. Now, coming to acute pancreatitis, if you look at the revised Atlanta classification, acute pancreatitis with organ dysfunction is severe acute pancreatitis. So it is something like sepsis. Here, instead of infection, you have acute pancreatitis plus organ dysfunction. And again, it's a complex disorder that develops as a dysregulated host response to cellular injury. Now, here the cellular injury is injury to the pancreatic acinar cells. And in the case of sepsis, it was infection by a microbe. And the diagnosis again here is made by 2 of 4 SIRS criteria and organ failure score of more than grade 2, according to modified Marshall grade. So look, there are so many similarities between sepsis and acute pancreatitis, and this will make my task easier on management of these patients. So it is also considered a medical emergency, much like sepsis. And therefore, the management depends on how quickly a patient comes to us, how quickly we can say it is likely to be severe acute pancreatitis, and how quickly we start managing these patients. And the management depends again on fluid resuscitation, IV analgesics, no antimicrobials, we'll come talk about that, and early enteral nutrition. These are the important management issues that we will discuss over the next 30 minutes or so. So I'll start with a presentation of a patient who came in with acute abdominal pain, which was severe, had vomitings, amylase was raised, X-ray abdomen was normal. She had tachycardia, and her oxygen saturation was about 92 on 2 liters of oxygen. So look here, she has tachycardia and she requires oxygen to maintain saturation. Ultrasound shows bulky pancreas, small fluid collections, and presence of gallbladder stones, bilirubin of 1.8, SGPT about 260. So she was diagnosed rightly as acute pancreatitis, but CT wasn't done. Because CT at this stage is not required, you can make the diagnosis based on clinical presentation and raised pancreatic enzymes. So on day 1, what are our concerns? How do we manage these patients? This patient requires hospitalization for sure. One of the questions that you should be asking is, when do we refer such a patient to a higher center if we are not working in a tertiary care center? What analgesics do we give? Because they often present with pain. In fact, that is the most common presentation. They require IV fluids. When to do CT, when not to do CT? Should we give antibiotics? If yes, when? And how about nutrition? When do we start nutrition? So the first question that a physician should be asking is, when do you refer? Now, if you look at the severity criteria, there are a lot of criteria, starting from Renson's and modified Glasgow's and Apache 2 and BICEP and many others. But practically speaking, there are 2 important things that I would emphasize. I'm not going into details of all those severity scores. If your patient has SIRS for more than 48 hours, you are looking at a patient who is likely to develop severe pancreatitis. Now, SIRS is rather easy to diagnose. 2 out of 4 criteria, you know it is SIRS. And if a patient already develops organ failure by the time he comes to you, then it is obviously severe acute pancreatitis. So clinically speaking, you can easily diagnose someone with predicted severe acute pancreatitis or someone who has already developed severe acute pancreatitis. And this can occur as early as 3 days, within 3 days of the onset of pain. Next, we come to analgesia, because the patient comes to us with abdominal pain. So we have to first treat the pain. So the question is, what is the right choice for analgesia? Should we give opioids or should we give NSAID? Because these are the 2 most commonly used analgesics. Now, concern with both of these is safety. Besides their efficacy, NSAIDs may cause renal dysfunction and GI bleeding, and opioids may cause ileus and respiratory depression. And these complications are seen in these patients regardless of analgesics. So they already have a propensity to develop some of these complications, and NSAID and analgesics might worsen them. So there isn't much data. In fact, we published a randomized trial comparing diclofenac with pentazocine, which is an opioid. It's a kappa opioid agonist. And we found that it is perhaps better than diclofenac, which is the most commonly used NSAIDs analgesic. So in this study, we randomized consecutive patients to either diclofenac or pentazocine given intravenously at 8-hour interval. And we also provided injection fentanyl through a patient-controlled analgesia pump as a rescue analgesia. And this, I can tell you, is a very important modality. So we thought that diclofenac would be better because it is both analgesic and anti-inflammatory. However, what we found was that pentazocine, the opioid analgesic, was better than diclofenac. And if you look here, the total dose of fentanyl for rescue analgesia was much lower in the pentazocine group, and the pain-free interval was also higher. Early this year, a similar randomized trial was published from PGI Chandigarh, where they compared diclofenac with another opioid, that's buprenorphine. And here also they randomized 48 patients, and they found that the need for rescue analgesia, that is fentanyl, was lower in the buprenorphine group, 130 versus 520 microgram. And in the same group, there was longer pain-free interval of 20 versus 4 hours. And this difference was also seen in those who had moderate to severe pancreatitis. So they also concluded that opioids are better than NSAIDs. So overall, we feel that opioid should be the first choice. Fentanyl should be given as rescue analgesia. And we found infusion pump as very effective in these patients. If required, you can always supplement with NSAIDs. There was a study published a couple of years ago that COX-2 inhibitors might be useful and also may decrease the severity of disease. This was a single center study, and this year in DDW, the same group presented data of multi-center study on COX-2 inhibitors, and they have again shown that there is benefit with regard to decrease in severity of pancreatitis. But I think there are some issues with this study, and we need to validate and to generalize the results. The next issue in the management of these patients is about fluid, because these patients are often nil by mouth because of intense pain. Now, the points we need to discuss: what is the usual fluid deficit in acute pancreatitis? What is the rate and type of fluid replacement? And how do you guide fluid therapy? So many years ago, the fluid loss was suggested to be very high, up to 5.5 to 6 liters in severe pancreatitis. But more recently, the median fluid loss was suggested to be around 3 liters. And based on the earlier reports, the recommendation was that these patients should be given very high amount of fluids. So the question is how aggressive we should be to manage these patients. One of the major problems with the fluid therapy is that there is no consensus on the definition of aggressive fluid resuscitation. Some people say bolus should be given or not to be given. How much we don't know. And the rate of infusion, you look here, 1.5 to 10 ml per kg per hour. That means we are talking about 3 to 8 liters of fluids a day. So there is a marked variability. But recent trial published in NEJM last year, comparing aggressive versus moderate fluids, is very helpful. So they randomized patients to aggressive fluids where they were given a bolus of 20 ml per kg, followed by 3 ml per kg per hour. In the moderate fluid category, they gave 1.5 ml per kg per hour, and a bolus was given only if there was hypovolemia or hypotension. And in this trial, they showed that aggressive fluids was detrimental. They randomized 249 patients. The primary outcome was incidence of moderate to severe pancreatitis, which was similar in both the groups, 22 versus 17%. But fluid overload was seen more in the aggressive group. In fact, the trial was stopped in the midterm because of the increased incidence of fluid overload in these patients. I want to draw your attention to why aggressive fluids might be detrimental in them, why there is a problem. Now, it depends on whether we are dealing with a patient with mild pancreatitis or severe pancreatitis. Now, in mild pancreatitis, there is preserved neurohumoral mechanisms and intact capillary circulation. Now, there is no systemic inflammation here. So, and there is no fluid deficit, no major leak. So even if you give aggressive fluids to these patients, there is potentially no significant harm because body will be able to clear out the extra fluid that you give and they have no organ dysfunction. Now, on the other hand, if you're a patient with severe acute pancreatitis, now these patients have a lot of cytokines and chemokines coming out into the circulation. Now they cause endothelial injury. And this will lead to fluid sequestration in the interstitium. And this leads to intravascular volume contraction, tissue hypoperfusion, and organ dysfunction. Now, if you give aggressive fluid, you give more and more fluids to these patients, you are going to perpetuate the whole problem here. So more fluid will come out, there'll be more tissue edema, and there'll be more organ dysfunction. So that is why aggressive in those with severe disease or predicted severe disease is likely to be harmful. Now look at the fluid distribution here. You have 2/3 intracellular fluid, 1/3 extracellular. And of these 1/3 extracellular, you have 3/4 the interstitium and 1/4 the intravascular volume. And this is what intravascular volume we are concerned about. So what happens is that there is an equilibrium between the extracellular and intracellular fluids. And the osmolality is also similar. But in patients with sepsis, which I showed you earlier, and also in patients with severe acute pancreatitis, this endothelial function gets deranged. Otherwise, it prevents leakage of any fluid or plasma proteins. But if the barrier is damaged here, then the plasma proteins and the fluid leaks out into the interstitium, and that causes major issues. The other thing you need to remember when you treat these patients is what happens when you give fluids intravascular. How much it retained in the intravascular compartment. You'd be surprised to see that if you give 1 liter of fluid of dextrose or linga-lactate, only about 100 to 250 ml of plasma volume is expanded. Now that means if you give 1 liter of linga-lactate, 750 will move out into the interstitium. And that in a patient with capillary leak and edema will cause major problems. So the next issue is which fluid do we give? And there is consensus here that linga-lactate is better than normal saline. It may lead, because saline may lead to hyperchloremic acidosis. And there is some evidence that lactate might then regulate inflammation. How do we monitor these patients? So there are certain goals that we want. This applies to any patient, regardless of the underlying disease. The mean arterial pressure should be around 70, whether it is sepsis, pancreatitis, liver failure, or anything. Hematocrit should be around 40, and we need a minimum urine output of about 0.5 to 1 ml per minute. The invasive way to monitor fluid is good only if you have an arterial lining, when you can measure stroke volume and arterial pressure waveform. This is generally not done unless a patient is very sick and in an ICU equipped with this. CVP, I can tell you, is not a good guide, and most people do not use CVP as a guide for fluid therapy. But I would like to suggest that non-invasive monitoring using a bedside ultrasound is a very good modality for fluid assessment, and this can be done by GI resident. You really don't need intensivists to do that for you. So look at the IVC diameter. If it is less than 1.5 or the index is more than 50%, there is fluid deficit. And you do a lung ultrasound for fluid overload. So IVC is very easy to see. Just keep your cursor just below the subcostal region and about 2 centimeters below the cavo-atrial junction. You can measure the IVC here, right? And in patients, and then you do a lung ultrasound. Lung ultrasound actually is a very easy technique. If you attend 1 or 2 sessions, training sessions, you can easily do it. The residents can do it. And if there are B lines, which are whitish, then you know a patient is having fluid overload and you should decrease the rate of amount of fluids. So having discussed this, what is the recommendation for fluid therapy in these patients? So generally speaking, about 3 liters of linga-lactate in 24 hours is what we generally give. Now, this is for the first 2 to 3 days. Beyond 3 days, your intake should be as per your output. So don't be too aggressive and don't underperfuse. So need optimal fluid therapy for patients with pancreatitis. The message that I would like to give is that by fluid therapy, we cannot convert a severe or predicted severe pancreatitis to mild pancreatitis. Fluid is not treatment for that. But we may worsen severe pancreatitis by giving more aggressive fluids. So that has to be kept in mind. Now, coming back to this patient was febrile, counts were 14,500, creatinine rose up to 2.4, bilirubin came down to 2.9, SGPT also decreased 78, blood and urine culture was sterile, and ultrasound showed only a small fluid collection. So mind you, what is happening here is that two things. One, there is fever and counts are up. So the question is it some kind of infection? So at this stage, the only infection we are worried about is cholangitis, because these patients who have got gallstone-induced pancreatitis might develop cholangitis, and then they require urgent ERCP. But if you look at the liver function test here, the bilirubin is down, the SGPT is decreased. That means there is no more biliary obstruction, or the biliary obstruction is getting relieved. In such a situation, it is highly unlikely that patient has cholangitis. So the fever and race counts at this stage are because of pancreatic and peripancreatic inflammation itself, not because of extra pancreatic infection. The development of renal dysfunction bothers us because she already had hypoxemia, but that means now she is having another organ dysfunction. And this again makes her having severe acute pancreatitis. So organ failure is key determinant of survival in these patients. So what happens in these patients is they have local injury and systemic inflammation, and it is the local injury which feeds into systemic inflammation. So you can have acinar cell injury, necrosis, fluid collections, and then these patients might develop organ failure, either renal or respiratory or both, or sometimes even circulatory. This is what happens. So the conceptual model here is the tissue injury leads to inflammation and severe inflammation leads to organ dysfunction. So you may have an acute event. For example, I showed you in the beginning about sepsis. You have an infection, or you have trauma, or you have pancreatitis. Either of these events will lead to local inflammation and tissue injury. What will subsequently happen is release of either pathogen-associated molecular patterns if there is infection, or if there is no infection, you have damage-associated molecular patterns or DAMs. These are small molecules which come out of the cells which are injured. And then they cause a pro-inflammatory response leading to systemic inflammation. Now, this systemic inflammation, if severe, may lead to organ failure. In some patients, there is a second hit, which can also lead to organ failure. And for example, here in patients with pancreatitis, the second hit could be infected necrosis. So what happens in these patients? There are three things. One is that there is pancreatic cellular necrosis here and fluid collection. Then there is increased the increased intestinal permeability because of severe inflammation. And they also have what is called as CARS, or compensatory anti-inflammatory response syndrome. So once you have severe SARS, body tries to bring down the systemic inflammation by CARS. And this is a state of relative immunosuppression. So these three things combined together lead to infected necrosis. Intestinal permeability is increased. There is a fertile ground with necrosis and fluid collection, and there is relative immunosuppression. And this again may lead to what we call as secondary organ dysfunction. So this is the paradigm here. You have acute pancreatitis, where you could have severe disease with a lot of activation of these cellular responses, both innate and adaptive immunity. A lot of cytokines come out, particularly IL-6, and we have shown that IL-6 actually correlates very well with development of organ dysfunction. And this is what we term as cytokine storm syndrome. And this may lead to organ dysfunction. On the other hand, you may have patients with mild pancreatitis where there isn't a lot of local injury or systemic inflammation. These cytokines are much less, and these patients recover very early, within a week most of the time. So if we have to decrease mortality in this group of patients with severe pancreatitis, we need certain targeted therapy for exaggerated, dysregulated immune response. So I mentioned right in the beginning that these patients have dysregulated, exaggerated immune response. So what is the impact of organ failure? So the impact here, you see there are 3 series that we published. We published in 2018. Another series same year came from Dutch pancreatitis group, published in Gut. And the third series was from Spain. Fairly large series here, number of patients quite large. You see here mortality in patients with persistent organ failure, 42% in our series, 38% in the Dutch series, and 52% in the Spanish series. So most patients who have got persistent organ failure are at a high risk of dying early in the course of the disease. And I'll come back to the management of organ failure in a little while. The other issues in the management of these patients include antibiotics and nutrition. So the question is, do prophylactic antibiotics have any role, either in mild AP or severe AP or necrotizing pancreatitis? And what are the problems with these prophylactic antibiotics? So in short, I can say that there have been many randomized trials, but most trials have not shown any benefit in terms of either reduction in mortality or even in infected necrosis. The problems which we see most of the times in these patients is that they develop multi-drug resistance infection, more gram-positive infections, and more fungal infections. And that is why in today's era, you should not be starting antibiotics and thinking that you are covering everything. This false belief of trying to cover everything is not a good idea. So my suggestion is that in the first week, unless you have a definite evidence of infection, for example, cholangitis or pneumonia or line sepsis, please do not give prophylactic antibiotics. The next is about nutrition. Now, these patients have pain, they are on IV fluids, but they need nutrition. So first couple of days is okay. I mean, giving IV fluid is fine. I showed you within 2-3 days, you can just maintain them IV fluids. So the question is, when do we start nutrition in mild and severe pancreatitis? And does the timing affect the outcome? And how do we give this enteral nutrition? So in general, the recommendations are that oral feeding in mild pancreatitis can be started as soon as your abdominal pain is decreasing. Patient does not necessarily has to be pain-free. You can start once you find abdominal pain is decreasing. Generally speaking, oral feeding is okay, but if patient cannot tolerate, then enteral tube feeding should be the primary therapy in those with predicted severe acute pancreatitis. Predicted means they have persistent SIRS, their organ dysfunction is starting, and you know it is likely to develop into severe disease. We should initiate enteral feeding as soon as possible, but within the first 24 or 48 hours, it is really not required. In fact, a randomized trial from the Dutch group showed that very early tube feeding was not associated with any improved outcomes. And polymeric feeds is all right in these patients. The target calories are 25 to 30 kilocalories per kg. Often it is difficult to reach, but even if you reach about 1000 to 1500 kilocalories in an adult, I think that should suffice in majority of patients. And we should aim to give 1.2 to 2 gram per kg protein in these patients, and rarely we rely on TPN. So in short, give enteral feeding, preferably tube feeding in predicted severe. Polymeric diet is okay, and our target calorie is about 1500 per day. Now I come back to this theme of organ failure and acute pancreatitis because this is what kills the patient. So I've talked about analgesics, I've talked about IV fluids, I've talked about nutrition and antibiotics. None of these therapy actually can decrease mortality by itself. That means if you give adequate fluids, we can't really decrease mortality. If you give very early nutrition, we possibly will not decrease mortality. But if we do not do that, we might increase mortality. So if we have to decrease mortality, we have to follow the guidelines I have just discussed. But to actually decrease mortality due to organ failure, we need something else. And that something else has to be a targeted therapy. So the question is there a potential therapy? So I showed you that systemic inflammation is a critical element for which we need target therapy in order to decrease mortality. And I've talked about this, but the issue is about targeted therapy. There have been some efforts in the past. I hope many of you would remember the PAF antagonist lexipefent was used, and this trial was published way back in 2005 and 6. And despite promise, it wasn't found to be useful. Probiotics were used because people thought that they may improve gut bacteria and thereby decrease chances of infection. In fact, it turned out to be the opposite. Probiotics led to increased mortality. Activated protein C again wasn't helpful. Pentoxifylline was shown to be beneficial in one small study, but a larger study from the same group did not show any benefit of that. So what do we need to do? As of now, I'll just show you some promising drugs which are under development in various trials. So there is a promising trial of TNF alpha antagonist. This is a trial ongoing in the UK. There are two trials ongoing on steroids, one in US, one in elsewhere. The third trial is on IL-6 antagonist tocilizumab in patients with predicted severe acute pancreatitis. Now, this year in DDW, the group from Thailand presented their results on 20 patients randomized to tocilizumab, and they did not show any great advantage of tocilizumab. I think there were many issues with the study design and the inclusion criteria. Once the study is published, then we can have a better understanding of what they did and whether it is going to be useful or not. Then there are certain newer concepts. Calcium, intracellular calcium is one of the important initial mechanisms how cellular injury occurs and how immune cells respond. So people have now testing ORI1 inhibitor as a very important modality in these patients. In fact, this randomized trial of ORI1 inhibitor by the name of Oxera was initially conducted in the US in many hospitals, but their recruitment was less. Then the trial was extended to India, many centers in India. I am sure some of the delegates must have participated in that. And I'm told now that the trial recruitment is over, and within next 3 months or so, we should have the preliminary results to understand whether it's going to be effective or not. And there are some trials on low molecular weight heparin, because coagulation is something that is activated in these patients with severe pancreatitis and might contribute to organ dysfunction. So I hope in the near future, we will have some positive results. We were interested in finding out whether steroids are helpful in these patients, and we tested the effect of methylprednisolone in a rat model of severe pancreatitis. And this was a model with L-arginine plus pancreatic duct ligation, where we showed that they develop very severe pancreatitis with organ dysfunction. And we measured direct markers of organ failure. Namely, we measured invasive blood pressure, heart rate, oxygen saturation, pH, and creatinine to mimic human severe acute pancreatitis. And what we found was that therapeutic steroids were beneficial in this model of severe acute pancreatitis. And based on our results and certain other studies, this actually presented this here in DW. Now we are starting a multicenter trial to treat and prevent organ failure in patients with predicted severe acute pancreatitis. The next talk would be on patients in second week or beyond. But just to make the transition smooth, I would say that in the second week, we continue enteral nutrition, intensive care in patients with severe pancreatitis. We watch out for infection. I showed you that's the second hit in these patients. This is the time for a CT scan if there is a suspicion of infected necrosis. So far, we don't do CT in the first week, generally speaking. And this is time for a watchful waiting. No intervention is required at this stage. And conservative treatment is the norm. So coming back to our patient recovered with conservative treatment over next 2 to 3 weeks and was discharged home. So ladies and gentlemen, I'd like to summarize by saying that acute pancreatitis, the first few days are critical for managing these patients. Adequate optimum hydration is important, not aggressive. We generally prefer opioid analgesics, which can be topped up by NSAIDs or sometimes even IV paracetamol. Early enteral nutrition is very important in these patients. There is no role for prophylactic antibiotics. You should refer a patient to a higher center if there is persistent surge or organ failure. This is something that you can easily assess yourself clinically, and no complex scoring system is required for that. And what we are awaiting now is targeted therapy to decrease mortality in patients with severe pancreatitis due to organ failure. Thank you very much for your kind attention. Happy to take questions.
Chaubal, you.
I think we'll take the question.
Later.
Oh, nice talk, Pramod. I think we'll take the question answers at the end of the second talk.
So you hand over the mic, please, to Dr. Pravir Rai.
Well, Dr. Pravir Rai can take.
Yeah. Very good evening. I think I would like to thank Professor Pramod Garg for this wonderful lecture, providing insight into the first week of illness, which is very, very crucial to manage mortality. I think in the first week, predominantly what we are doing is managing SIRS. However, in the second week and beyond, the problem is infection and occurrence of local complications, predominantly in patients with severe acute pancreatitis in the form of acute necrotic collections. And these collections obviously can become infected. So management in 6 weeks and beyond predominantly involves antibiotics and drainage of the infected pancreatic necrosis by different modalities, which include endoscopic, radiologic, surgical, sometimes a combined modality. And to understand these concepts clearly, we have with us Dr. Vivek Kaul, who is a close friend and a brilliant academician. So let's hear Dr. Vivek Kaul.
Thanks, Pravir. Hope you guys can hear me okay. Thank you, Dr. TSC, for inviting me to speak here. It's always a pleasure to be part of this particular series. Can you guys see my the slide set? And I will go to presentation mode.
You're able to see the slides.
Perfect, thank you. I have to say that listening to Pramod, what a masterful lecture. And I feel like all the most important and in fact even upcoming concepts in acute pancreatitis, severe acute pancreatitis, were masterfully demonstrated by Dr. Garg, and I thank him for that. I in fact felt like when this topic was given to me, I felt like I should pay some money to Dr. Garg and switch it, because the first week versus second to 6th week, I felt like I have to go through the textbook of pancreatitis here. But I'll do my best, and I think most of the concepts have been very clearly enunciated, and the handoff was perfect. I would reiterate that it's not even the first few days at our center. In my experience, the first 6 to 12 hours of what happened to the patient is so critical. And I feel that those patients that don't do well despite our best efforts, if you look back in their chart, they have spent the first 12 to 24 hours somewhere in the field where they were victims of the cytokine cascade and third spacing. So we put a lot of emphasis on the first. In fact, I don't know if many of you have heard this term, but I kind of coined a term called door to fluid time several years ago, similar to what they have in angioplasty, which is the door to balloon time. So I think the door to fluid time still remains a gap in severe acute pancreatitis in the first 24 hours. But my charge is the 2nd to the 6th week. And here are my objectives. The basic premise here is to discuss the optimal, the issues that arise in the 2nd week onwards, some of which are already alluded to. I'll talk to the currently understood optimal management of these conditions, both from a diagnostic perspective as well as from a therapeutic perspective as well. Obviously, as Pravir mentioned very astutely, the vast majority of these issues relate to local complications such as pancreatic fluid collections, but I'll also want to highlight some of the other areas where we haven't done so well traditionally as a medical community, and I think where some of the research gaps exist as well. I'll try to summarize the available literature, and we can have a discussion about the gaps in research. So the time course and the severity indices of acute pancreatitis are listed on this slide. The revised Atlanta classification really helped us a lot. The mild and moderate patients, we don't tend to worry about too much, but the severe patients are characterized by organ failure, by severe SIRS, and multi-organ dysfunction. Obviously, from a textbook perspective, the interstitial and edematous type of pancreatitis is one type, and the necrotizing one is the one that we are more afraid about. And it's the patient with the organ failure that then also correlates with necrotizing pancreatitis. These are the patients who will develop pancreatic fluid collections closer to the third and fourth week, and will have more often than not walled-off necrosis. Now, a lot of my discussion is focused around the guidelines. There are several of them, including the more recent one just came out from the American College. The American College has invested a lot of time and effort in this space. Of course, there is international guidance as well. The AGH came out with a clinical practice update. I would encourage all of you to look at CPUs that actually serve as a bridge between two guidelines. So these are practice updates that come out. They have the relatively new knowledge, which might make it to the formal guidelines down the road. So AGA CPUs are very helpful. We're all aware of the NICE guidelines from the British Society that does a very, very innovative work in the space, and really vets down the available data and publishes it in a very practical form. So the guidelines serve multiple purposes. They tell us about classification of disease states, obviously tell us about risk stratification, and then give us data-based guidance, level 1, 2, and 3 in terms of managing complication. But as Dr. Garg pointed out, there are actually no specific approved therapies for acute pancreatitis, but the way medical treatments have gone in the last 50 years, I think now is the time where for the first time we have real hope that we might have targeted therapies coming out, especially in the first week, where we can impact the outcome for the subsequent time period for the patient. So not here yet, but very hopeful that that will come. The timeline for acute pancreatitis has been referred to already. About 15 to 20% of patients will have severe disease resulting in necrotizing pancreatitis and persistent organ failure. A lot of the times the necrosis is sterile, which is where the concept of percutaneous sterile aspiration guided antibiotic therapy comes from. And then, of course, a lot of the times the necrosis is infected, and that's where we get involved because we go from the per oral route. There is also walled-off pancreatic necrosis as a term that was kind of defined a few years ago, and we need to use these terminologies to the care of our patients. So this is the area that we're focusing on mostly. The patient who does well, and we most of the time don't hear much about them in the future. Now, in terms of management, this is the timeline-based management. Of course, Pramod has referred very nicely to the early time and then left off where enteral nutrition really becomes a critical need. He has done a great job with referring to the antibiotics and their role currently understood, and I will dive into that in one slide in a couple of minutes. I will focus a little bit more on the minimally invasive therapies for local complications. And just keep in mind that although about half the deaths occur in the first week or so, an equal amount of morbidity and mortality occurs in suboptimally managed patients in the remaining weeks. So as a high-level view, this is what the talk will be mostly about. Remember, the SIRS does come in the first week, but it does persist in many patients through the second, third, fourth weeks in varying kind of degrees of severity. And this is around the time when multi-organ failure is well established, and these patients are typically in higher-level ICU beds or step-down units. They're not doing well. They don't look good. They're in a lot of pain. And around this time, your efforts at giving any IV fluids and partial parenteral nutrition or even early TPN, which seems to be a low threshold, now becomes a real problem. Now we're looking at real nutritional needs. Infection has started to set in, and these patients will develop varying degrees of pancreatic insufficiency. And then will come other complications such as the catastrophic vascular complications and some of the more disruptive issues that we are called upon to deal with. Pancreatic fluid collections are by far the most common reasons for GI consults in these patients in the week 2 to 6 or beyond. And I will dive into that a little bit. The management principles are listed here. Obviously, the most important thing that over and above anything else that we do is continuing to provide supportive care as well as good critical care for these patients. And this is why centers of excellence are important in this realm, because this is not always possible consistently and in smaller centers that don't have the expertise or the experience. Nutrition cannot be overemphasized. Pain management, I think, is a gap that we are not very good at still, and I'll speak to that a little bit. And of course, early identification and treatment of potential complications. The one important principle in this realm that I always talk about is that management of the complicated pancreatitis patient is not a one-person deal. This is a team effort and requires a lot of people with very high level of skill sets, and typically, again, available at the tertiary or quaternary level facilities. Over and above that, we need other ancillary services to be in place, because some of these patients will be in-house for very long and get really debilitated physically, as well as have varying degrees of cachexia, sarcopenia, psychological distress, and so forth. So this is a big problem that has not been consistently met across the board, and we're happy to talk about that in the discussion. Pain management is one of my personal frustrations. I'm not an expert in pain management, but I do see these patients and I see them in pain. There are currently no formal guidelines for pain management, and I think this is an area of research and something for us to consider at the society levels. Obviously, opioids and NSAIDs remain the current management, but I think this is a multimodal strategy. A lot of these patients are on PCA or patient-controlled anesthesia pumps. One has to be careful that too much NSAIDs may be already bad for someone who's in renal failure already, but I think it's a good guide to use the WHO analgesia ladder listed here, starting with some NSAIDs, adding some varying degrees of opioid potencies as we go along, and then of course some local treatments which come from our anesthesia team members. A step-down approach is usually helpful for severe cases, especially if there is other limitations on per oral approaches. So I think the epidural approach needs to be kept in mind. I think there should be a low threshold for getting the experts involved for managing pain. Similarly, for malnutrition, there is a big issue here. We have a very low threshold for TPN, but the guidelines and the recommendations are very clear. The SIRS response creates a huge catabolic state. The intestinal transit is at risk as well. There is increased bacteremia from vascular compromise of the gut, and this is actually a board question. Pretty much every year in the GI boards in America, this question is asked, and what is the best way of feeding a pancreatitis patient? And the answer is enteral nutrition, and this should be started as soon as possible. Not always easy to do, but the guidance remains. In terms of CPUs, this is an AGA guidance on nutritional management. This is about 3-4 years old. So point your attention to this first column here. This is early addressing. Obviously, if patient is able to tolerate food, you should feed them, but many patients are not. So if they are able to, if they're having ileus or obstruction, then you go to the enteral nutrition route through a feeding tube, whether it's an NG or NJ. That has been studied, and I think the data is kind of mixed on that. But we should keep trying that as much as possible, as long as there is no ileus or bowel obstruction. For those patients who are not able to tolerate this type of feeding or have nasal irritation, we then go to formal endoscopically placed or IR placed feeding tubes. And if they can tolerate NG tubes, we can go to a PEG tube. If not, then we have to deliver the food much distally and so forth. So various options are there. The problem is not in not having options. The problem is that we have a low threshold of going with TPN, and that remains an issue at many centers. And the other problem that I think is insurmountable to a great degree is that a lot of these patients will have pretty significant ileus and or mechanical obstruction, which will limit our ability to feed them. So fully recognize the issues, but I think we should keep this algorithm in mind and use it as often as the physics of the patient allow us to. Moving on to infectious complications, obviously, this is a high morbidity state in no small part related to infections. Cholangitis comes from many sources, retained CBD stones, distal CBD stricture, and so forth. These are patients who are sick and they get sicker with these infections. The pancreatic pseudocysts get infected, and so forth. Now, the important teaching point here, especially for the young folks, is that infection and SIRS kind of mimic themselves, right? So both patients will have fever, tachycardia, tachypnea, leukocytosis. So how do you differentiate with these between the SIRS response, which is obviously a sterile response, or in florid infection or sepsis? Well, blood cultures and pan cultures are definitely helpful. There's also a concept of clinical judgment and suspicion, which comes with time and experience. But long story short, empiric antibiotics, as Pramod very clearly said, really only when you have a very high degree of suspicion or documented infection. Otherwise, follow the cultures and discontinue the antibiotics as soon as you have evidence of no active infection. As with any surgical principle for managing infection, drainage of a collection is the most important thing, even more important than antibiotics, and it's important to keep that in mind. So therefore, prophylactic antibiotics are not recommended. Follow the cultures, drain the collections, and have a low threshold of calling your infectious disease specialist. They are really helpful, because one of the problems we have in these high-end antibiotics is drug-resistant bacteria. And even if 1 or 2 patients in the hospital have that, that's already too many people. EPI develops in a wide variety of patients. Acute EPI is more common. I think the mild and moderate patients usually will recover, but the severe patients will develop persistent EPI. And this is another area, both in this population as well as in the post-surgical population for cancer and such. We have not been consistently very good at assessing for EPI and how it factors into nutrition and well-being. So I think keep an eye towards replacing pancreas enzymes in those patients who may be at highest risk, because this damage does occur similar to the endocrine damage, which occurs in the most severe patients. Obviously, if you lose pancreatic mass, and if you lose enough of the pancreatic mass, you're going to get some degree of islet cell dysfunction. There is some discussion around the fact that whether necrosis or necrosectomy will help with that, but I don't know that that's been studied extensively or in a prospective fashion. So EPI and endocrine deficiencies will come around the 3, 4, 5, 6 weeks, and that is something to keep in mind. Relatively easy to treat if you're looking for it. We talked a little bit about the vascular complications. I've personally had the misfortune of dealing with these, both coming in as de novo cases, as well as cases related to the new era of lumen-opposing metal stenting. As you can see here, an angiogram showing the blush as well as a clot within a lumen-opposing stent. So this is a very physical event that occurs from the proteolytic activity of the pancreatic enzymes, and develops roughly around the 2nd to the 4th week. It can be pretty catastrophic. It's not hard to diagnose based on the patient's lab and clinical and imaging criteria. And most often it's the splenic artery that's involved, but pretty much any vessel in the vicinity can be involved. Now, the good news here is that if the patient gets to help quickly, and the center does have the appropriate IR and interventional facilities, then I think the treatment success is nowadays pretty significantly successful. One caveat here is that we have seen, and we'll talk about this in the discussion if others have as well, is that the initial CT angios may be negative or maybe low yield. So have a low threshold for repeating the CAT scans, the angiograms in these patients at the 6 to 12 hour mark, especially if there is clinical evidence of ongoing bleeding. We did publish recently in the American College meeting last year a novel approach where 2 CT angios, 2 embolizations, multiple endoscopies were not effective completely, and the patient continued to ooze, and we were able to stop the bleeding finally by doing a novel intervention, which is the installation of a Purostat gel, because in that case there was no active vessel that was bleeding, but the back wall was oozing. So not an on-label indication for that product, but sometimes you have to think outside the box when you're facing these type of bizarre complications. Now, venous thrombosis, of course, is well known. I think this is another board question that comes where they show you a gastric varix and give you somewhat of a history of pancreatitis, and the answer is splenic vein thrombosis. This does occur. I think it's a common finding, not nearly as catastrophic as your pseudoaneurysms, but it's something to be kept in mind and may have long-term consequences for the patient. In terms of anticoagulation treatment of these, it's not clear to me that this is widely agreed upon, but I think if there is evidence that this is a relatively new clot, then I think just like in liver disease, we should probably use anticoagulation judiciously as long as there are no other bleeding events going on. Hemosuccus pancreaticus is more difficult if it's persistent and active and significant. These are vessels that feed into the pancreas parenchyma, into the side branches, or coming from the pancreatic duct itself. It's not typically caused by instrumentation in this situation. It's usually the natural history of the disease, but can result from instrumentation as well if you hit a vessel in the vicinity while you're doing endoscopy. Now, this is a more difficult IR problem because these are relatively smaller end vessels that are bleeding, and the typical endoscopic appearance is shown here. Now, one of the important kind of caveats for fellows and young faculty is that if you have a patient with GI bleeding in the setting of severe pancreatitis, a regular upper endoscopy is negative. Think of hemosuccus pancreaticus. There is blood in the small bowel, and a side viewing endoscope may be able to get you the diagnosis before you go on a wild goose chase. So an important diagnosis, and this picture is also shown on the GI boards not infrequently, and the answer is hemosuccus pancreaticus. Now coming to one of our favorite diagnoses, which is a disrupted pancreatic duct syndrome. This is a problem. It is a problem that has plagued us forever. These starting to occur in the first week and then really get matured and established in the second week onwards. So basically, it's a direct result of the inflammation in the pancreas. It can occur at any location, but typically found in the mid-body. These patients will continue to leak. They'll have pancreatic ascites. They'll have pancreatic pleural effusions, and they will not get better because they are continuing to have a vicious cycle of inflammation and physical trauma in that location. ERCP has been the gold standard, and I've generally seen that ERCP is more successful the early on that you are in the space. So unlike bile leaks, this becomes important. What the timing of ERCP here is, patients who come to us very late, the ducts are already scarred off, and there's really no entry point. So I think early intervention is better if you're facing this scenario. Thankfully, EUS-guided pancreatic duct interventions have helped save the day, but at least in America, we only recently got the 6 French cystotome. The devices and techniques are not fully matured for this intervention, although many of us are performing this with varying degrees of success for patients who can't get ERCP. So here's a case, a patient ductal disruption, more in a bit mid-body here, relatively early, and we were lucky enough to get a wire across the disrupted area early on, relatively in the case. And this is the case that had significant pleural effusion here. You can see almost like a hydrothorax. And then this patient came subsequently to many procedures here. This is an MRCP image showing both a downstream as well as a mid-body kind of cutoff here. We try to get MRCPs in patients before we intervene, as long as they can travel to these imaging tests and so forth. They're not always possible, but in this case, we had that guidance. And if you see here, this pancreatogram, I try to limit the pancreas injection. I already know the anatomy from the MRCP. You can see there is contrast in the upstream duct, very similar to the duct over here, but there's not much contrast filling the remainder of the duct, which has multifocal disruptive areas. So as time went on, we balloon dilated this and kind of reconstructed the duct. You can see here some areas of narrowing which resolved, and then downstream as well, you can see the degree of irregularity and scarring here. Relatively fresh case, so it's not very stenotic, but you can appreciate that throughout the duct, the patient has significant distortion and stricturing. And then, of course, you end up doing the pancreatic stent. You can see the contour of the stent, if this projects well, is really very different than, it's kind of zigzagging around. It's just following the tortuous scarred area in the duct. And this patient recovered fully. But this is a good case scenario where we were able to do everything we wanted to do. But that's not always possible if the patient comes to you late. So with that, we move into kind of the last section of this talk, which is fluid collections, walled-off necrosis, pseudocysts, and so forth. A lot has been discussed on this topic, but I wanted to save it for the last. The revised Atlanta classification really told us how to classify these, and they are listed here: the acute peripancreatic collection, the acute necrotic collection, and then, of course, the pseudocyst and the necrosis. Two different kind of things that come to the table, but we'll talk about the management of these in the next few slides. So an important board question also comes up is pancreatic pseudocyst management. I know this is relatively simple knowledge, but so often we get referrals, and so often do I see that asymptomatic pseudocysts are being intervened on, and then these patients get into trouble. So reserve the interventions for symptomatic patients, whatever the symptoms are, whether it's sepsis or whether it's local infection, obstruction, infection or bleeding, pain, rapid enlargement. Those are all kosher. But patients coming in with relatively any size pseudocyst who are walking around, have no symptoms, wait and watch is the traditional approach. Now, before we were in the business, up until recently, and in fact, even now in many communities, a lot of these are being drained by surgery or by percutaneously by IR. I distinctly remember a case from our community, actually, a couple of years ago, that had two cyst gastrostomies surgically, and then finally had a recurrence. And then it was sent to me for EUS guided drainage. So surgical drainage is still happening, even though there is pretty good evidence now that the EUS guided route is the way to go. So classic appearance of a non-necrotic collection, and this is the anatomical correlates here. I won't go into too much detail, but if there is one area where you can use the plastic stent still and get away from the lumen opposing stents, that is for a transgastric drainage of a clear fluid collection. Wouldn't recommend this in the duodenum. The rates for perforation and wall disruption could be a little bit higher from the duodenal location. So this was one of the earlier randomized trials on a relatively small number of patients, EUS guided versus surgical cyst gastrostomy. And obviously the length of stay was less, cost was less, and the overall outcomes were similar. So this set the stage for further studies. And this is a meta-analysis of about 7 studies showing that endoscopic drainage is favored both from a clinical perspective, but also from a technical perspective. And that has kind of become the gold standard for these patients. And we've had no issues on a multidisciplinary team setup to position this as the preferred option for managing these patients. And there's enough literature on that at this point. These are some of the stents that are available across the world. We pretty much have the Access stent in this country, and I know you folks have access to some others. There are some other ones that are available in the European countries, mainly differ in the shaft width, so to speak, in the design of the biflange, and of course varying diameters depending on the application. So necrotic fluid collections, again, is something that is the bane of our existence. It does occur in about 1/4 of the patients. Mortality is high in necrosis, as Dr. Garg had pointed out. And as I mentioned, this is one area where lumen opposing stents can be significantly more superior to the plastic stents because they provide a wider gateway for interventions. And more recently, our surgical colleagues have also helped us out with the video-assisted retroperitoneal debridement approach, the so-called VAR technique. Hasn't quite taken on that much in America, to my knowledge. But we can talk about the pros and cons of that approach as well, along with the percutaneous approach. The key thing here is that these patients will be coming back to the unit multiple times. They require multiple interventions and frequently require multimodal interventions as well. And there is a finite amount of complication rates associated with endoscopic therapy, which we cannot ignore. So classic appearance of a case that is definitely headed your way. This is a patient whose pancreas is basically completely destroyed and will likely present with the necrotic fluid collections. You can even see in a CAT scan the heterogeneity in the collection, and the EUS is so good at bringing this out, and you have to be prepared to put a lumen opposing stent in these situations as opposed to a plastic stent. So this is the kind of the final guidance on the necrotic fluid collections. SEMS or LAMS, a step-up approach, as the Hyderabad group has shown us a few years ago. We keep our IR folks on hand, especially for the paracolic collections and collections that are not accessible by EUS, and they do a great job in many of these patients. Surgical approaches I've already referred to. I think the new kid on the block is relatively the VARDS approach. Rarely do these patients have to go for open surgery anymore, and as we have seen in the literature and in our experience, the outcomes are not great. So this is the final word on necrotic management, and again, it's not consistently being done still in the Western world, where smaller communities, medium-sized communities, and care teams that are not aware of the recent paradigms are still subjecting patients to surgery. And I think that's where some of these educational events are very useful, because we can actually speak to the latest data and establish guidance and disseminate this type of information. So again, a summary of the endoscopic step-up approach: EUS-guided drainage, necrosectomy, use percutaneous drainage where necessary, and then minimally invasive surgery, which still is kind of sort of on the uptake. Typical images of a really bad necrotic collection, the inside view, and then of course somewhat well into the necrosectomy phase where the cleanup has been done. Again, our typical approach is to place a lumen opposing stent, get a double pigtail in. We believe in keeping the back wall away from the splenic artery. Doesn't always guarantee lack of bleeding, but we can talk about that approach. And the wider the stent, the better the removal of these debris is in general. The surgical step-up approach is basically those patients who don't have or have had EUS-guided drainage but now need additional work, and this is kind of the algorithm for those patients. As I mentioned, the open surgical interventions are relatively rare. So this is not an uncommon picture in patients like these. These are patients that are hanging around for days and weeks. Sometimes they go home, but then they come back, and if you do a scout film on them, they have a variety of hardware going in and out of their abdomen. But if you look at them, they might look okay to you, but they have a lot going on. And this is a kind of a curious thing, using a percutaneous esophageal stent just to kind of debride out, provide a gateway. Obviously, this type of patient will develop a fistula, but this is a relatively rare event, and I'm not recommending that in every case, but just wanted to show that. New kid on the block in this space is the so-called endorotor device. This is a high-speed rotational blade with suction, and this came out around a couple, 3 years ago. It was originally designed for endoscopic resection of scarred lesions, but this larger diameter catheter, which requires a 6-millimeter scope channel, is very effective in managing these necrotic collections, as you can see here in this video. One has to be careful that you don't suck on a vessel, but with the few cases experience, you can actually get pretty good at it, and very effective. And there is some good recent publications on that I've cited here as well. So something to see. This space has not had too many dedicated devices, but I think that this is one step forward. There's also some caps that have come to assist us with this. But I think in one session, you can get more than 50% of this cavity done. And we can talk a little bit more about it in our discussion. So take-home points: morbidity remains a big part of the 2nd to the 6th week, but mortality is not too far behind the first week cohort, especially if you are not doing the right things, especially nutrition, especially infection control, and managing contained collections. Persistent SIRS is a continuum. This is almost, think of it as an alpha rhythm in the first 4 weeks, and this increases the catabolic rate, contributes to the pain, and of course, the overall well-being of the patient is not good as long as SIRS and pain remain. There are guideline-based recommendations for nutrition, fluid collection management, and infection, but I think pain management and overall wellness need some attention, I think, and it is all our responsibilities to look at how we could best position those guidances in our respective communities. I think more emphasis needs to be paid to that. Obviously, it's a multimodal disease state where endoscopic, percutaneous, and surgical therapies rarely are needed. But I think for the most part, endoscopy and percutaneous approaches, along with good systemic therapies and nutrition, will save most of the patients. One point I do want to make is that this is one disease state very similar to the end-stage liver disease patient and very similar to the severe IBD patient, that we really require a Herculean multidisciplinary effort with time and cost and commitment to save, recover, rehab, and rehabilitate these patients. This is not an easy job. And I think that's why teams do better, bigger centers do better, and these patients do belong, I think, in centers of excellence for this work. And we are very fortunate here to work here and work with this team. This is just a snapshot of I think, 9 attendings we have, or 10 attendings who are focused on pancreatic surgery and pancreatic endoscopy, along with dozens and dozens and dozens of people who are working in the ICU, in the surgical ICU, and the pharmacy, and the pain management, radiology, and all the subspecialties of medical surgical areas that help with these patients. So big thank you to our team. And with that, I'll close out this lecture, and hopefully we'll have a robust discussion around these points. And thanks again for the invitation.
Okay. I think Praveer, we will all start, and Chaubal. I like to promote Garg one statement. All these efforts you need to do that, not that it's going to decrease the mortality, but it will not increase the mortality. But what is there to decrease the mortality? You said targeted therapy. That is a very, very important statement. You do it to not to increase the mortality, but you have to aim at something. And I liked Dr. Vivek call fantastic exposition. Both of you did it. And we covered from the day 1 to the 6th week what all is going to happen in this. And you said is, I like the word pancreatic rehabilitation. I think that is the thing we need to take care of that. You can have exocrine, endocrine, even Dr. Pramod Garg. Now let's have the quick question, and last 10 minutes I will have the chit chat session. We'll start from Dr. Chaubal and Dr. Praveer Roy. And what are your the discussion interaction with the speakers? We had 2 fantastic speakers and very nice coverage of the pancreatitis. And Chaubal starting with. And I have 40 questions here.
Yes, sir.
Delegates, if time permits, I'll try to be. I want all of you to be very brief in the question, and same way they very brief in the answer. Okay.
I will ask just a question to Pramod. See, you are. What is your opinion regarding so many prognostic and scoring systems which are there for acute pancreatitis? What is actually the accuracy of all those prognostic scoring systems? How accurate are they in really predicting that this patient is going to progress to severe pancreatitis in this thing? So, what is the positive predictive value of various kinds of scoring systems that you have? There are as many as I think 9 or 10 scoring systems for the severity of pancreatitis.
Unmute Pramod.
So my short answer is that for practical purposes for managing, SIRS is a very important clinical criteria. If you have a patient who has persistent SIRS more than 24 hours, you got to be worried. More than 48 hours, definitely this patient is going to have problems. SIRS alone doesn't have a high positive predictive value, about 20%. And we have seen and actually published that if you add IL-6 to SIRS, then your positive predictive value actually goes up. So as a single prognostic marker, we have now seen IL-6 to be a very important parameter. In fact, we do it every day now in most patients. And this happened only after COVID, because in COVID, we started testing for IL-6 almost on a daily basis, and then we continued with that in acute pancreatitis also. When you have to do multi-center studies and research studies, then you need to have those parameter scoring systems, because then you can compare data from different centers. You have to show very clearly how the disease has progressed or improved. So both are different. For studies are different, and for practical management, I would say SIRS and IL-6 are very good.
So that means for study purpose, all these criteria, for the practical day-to-day management, you have your own way of assessing. Sometimes the people say that he is having good appetite and able to tolerate. That is itself a road to recovery. Something like that is a good astute clinician. At the end of the day, all the parameters, how the clinician judgment is very important. Yes,
So I'll
Chaubal.
reverse this. I'll just reverse this question. That if you have a scoring system, the mild pancreatitis, how many progress to severe pancreatitis in spite of being shown as a mild pancreatitis?
No, again, it depends. I mean, no scoring system has 100% sensitivity or accuracy. Okay, so if you have a patient with bicep score of 1 or 2, patient might progress to moderate to severe disease later during the course of the disease. So your whole idea is to have some assessment within the first 2 to 3 days as to where the patient goes. He remains in a facility where adequate management can be done, or he goes to a higher facility where you have multidisciplinary approach. And Dr. Call showed that you have to have a team of 5-6 people looking at the patient. So it all depends on your assessment where the disease trajectory is likely to go.
We will alternate question to one speaker to other. Next question from Dr. Praveen Roy to.
Yeah. So, Dr. Vivek, an excellent talk. You mentioned in your talk about, you showed a flow diagram mentioning about PEG in patients with severe acute pancreatitis. So how commonly do we need that? Because is that really common?
Yeah, so this is, you touch on a pain point for me personally. So before I answer that question, I want to 1000% support Pramod's concept of the SIRS being the number one practical point. We've been using it forever, and there is actually textbook guidance on this as well in the first 24, 48, and then beyond 72 hours. It very well correlates with patient outcomes. Second thing I will add to that, we don't do routinely IL-6, but we do CRP, BUN, and hematocrit. And I also look at, this is not something I published on, is the total fluid volume in the first 24 to 48 hours. If the hematocrit is not moving despite 6 to 10 liters, that patient is a problem patient. That is, so BUN, hematocrit, CRP, and total fluid volume, and the other SIRS criteria, very, very important. And the other stuff is for the research. To answer your question, I think you're absolutely right. In the first couple of weeks, you would probably get away with a combination of fluids and some PPN, maybe partial parenteral nutrition that does not require a central line, and some combination of nasogastric feeding. So if you saw in my talk, I said that, once you get beyond the 2-week mark, the nasal irritation starts. It becomes clear which direction this patient is going. This patient is not leaving the hospital for several weeks. That is the time that you need to proactively think of doing something different, whether it's a G tube, you place it, IR place it, J tube, depending on ascites and gastric dysmotility and all of that. But then the NG tube is the first guide as to what the patient will do. If they're tolerating the NG tube, then you consider a G tube. It's just like a concept of intubation and tracheostomy, right? So the ICU people will put a tracheostomy as soon as they know this patient is not going to the home next day. So I think it's a kind of a clinical judgment there too, but not an easy question. No question about it.
Chaubal, you have one more question to ask, you said?
Regarding this goal-directed therapy, people have been using this particular goal-directed therapy to manage these patients. How effective is this particular approach in really preventing the subsequent development of pancreatic necrosis or pancreatic infection, etc.? The recent guidelines of ACG, I think, which are published in 2024, just now, I think, March, they have again raised a sort of a doubt in this particular directed therapy. It is not effective as far as
Your voice is.
So that's okay. I could get his point is about goal-directed therapy. Now, I think let's make a distinction between goal-directed therapy and the goals that I want. So what I showed you, that if somebody asked me what's the minimal blood pressure you want, I would say I would want a minimum blood pressure of 70 MAP, right? What's the minimum urine output you want? I would say 1 ml is good, but even 0.5 ml, I'm okay. So when I say what are the goals that I'm looking for, these are the goals. Now, when you talk about goal-directed therapy, this concept came in patients with sepsis, where they said you do whatever you can to achieve these goals. And then it was found that it wasn't that effective or much better than the conventional therapy. Now, the reason for that is that in conventional therapy also, you are doing whatever you can to achieve those goals. So the reason why the particular particular saying that goal-directed therapy is required went out of repute. Went out of repute. And the reason is that now, whatever you do, these are your goals.
Okay, I think we made it very clear about it. Praveen Rai, you have a question to.
Yeah, I think, Dr. Kaul, you touched upon many aspects of pancreatitis in 2nd to 6th week. So one more problem that we see is sometimes a colonic communication. We have infected necrosis, and then sometimes there is colonic perforation. Usually these patients are not very toxic to begin with. So how do you manage these patients?
Yeah, so the contiguous involvement of bowel, viscera, and other organs is something that we see. Fortunately, not that commonly, but obviously your denominator in India is much larger, right? So you probably see these even more than us. But these are real problems, and they can present both acutely and they can also present more subacutely with fistulizing disease and mechanical compression, which is why I mentioned earlier that one of the limitations of enteral feeding is physics of the abdomen. If you have proximal or distal obstruction, whether it's partial, relative, total, or fistulizing disease, it makes enteral feeding much more difficult. So how do we manage these? Well, I mean, obviously, if there is a insulting collection that is weighing down on the colon, whether or not it's perforated, that has to be managed. If we can't deal with it, it has to be drained with IR. Obviously, for fistulizing disease, it becomes more difficult. These are not easy fistulae to close. And certainly, if they're more proximal in the colon, that become more harder. With the full thickness clips, you can give it a shot. Suturing is not easy given the instruments we have right now and the tissue friability. Plugging with glue and stuff has been attempted as well. But I can tell you that, in the more severe issues where endoscopic or percutaneous therapies will not help, these are maybe the patients who can go for a very focused surgery and resect the disease segment, maybe provide an ostomy while the other work goes on. So I'm not anti-surgery. I think surgery has to have a goal, and these might be the patients that might benefit the most, because even covered stents are not going to be easy to retain there. You can place them there, but you may not be able to retain them there. So it's a difficult problem.
Okay, good. Thank you, Dr. Vivek. Now I have a question on behalf of the delegates, rapid fire questions to both the speakers. We have that. Both of you, procalcitonin cutoff in difference in SIRS versus sepsis. You have any cutoff, or we cannot do that?
Cutoff is not in the value, cutoff is in the timing. First week, procalcitonin is not very helpful. From 2nd week onwards, it becomes helpful.
Okay. Any difference of opinion?
No, I agree. I think, again,
okay, now
you guys
the question is, sometimes patient is not able to tell you exactly the onset of pain. You are not able to tell you the 1st week or 2nd week or 3rd week. In that situation, how will you differentiate SIRS versus sepsis?
No,
for me,
you always have a rough guide that you are 5-6 days old pancreatitis, or it is 2-3 days old, even if patient is not clear about the day of onset. So generally speaking, it is 2nd week onward that you will start thinking of infection.
So the history is very crucial.
Very important.
We develop the pain, that is very important. Is there any way we can differentiate SIRS versus sepsis? Vivek, sorry, you want to say
No, sorry, go ahead. I was just going to
Is there
add
any
that,
way we can differentiate SIRS versus sepsis in the...
No, as I mentioned, I had a specific line to that thing, that SIRS and sepsis behave exactly the same. They are two sides of the coin. And I think clinical experience, parameters, just knowing the patient and how the trend goes. This point in time is not that helpful. The trend is more important. Of course, culturing the patient, you will culture the SIRS patient and you'll culture the sepsis patient. So following the culture is very important. But I just wanted to make a point, especially for the youngsters, is that in general, I don't know how much this is talked about, but biliary and post-ERCP pancreatitis have a very acute onset. Patient can tell you that they were on the couch watching the Netflix and the pain started. Alcoholic and drug-induced pancreatitis or some other etiologies have a more subacute onset, and it's very hard to know exactly when the inciting episode started. But for biliary and post-ERCP, the timeline is more clear.
I think that's a very valid point. For biliary and post-ERCP, exactly you are able to pinpoint. In alcohol, sometimes maybe different. There, the problem comes SARS versus sepsis.
Yeah.
Is the yes,
Praveen
Yeah.
has a point, I think.
Yeah, so actually, I think the question that is coming for SARS versus sepsis, I think there are few studies, and some of these studies have reported a cutoff of around 0.25 mg per liter. But the problem in that study is the sensitivity and specificity was quite low. So the sensitivity was only around 70% and the specificity of around 40%. So there have been studies, the cutoff was 0.25 mg per liter to differentiate, but again, very low sensitivity and specificity for those studies.
okay. Now the another question is the ilinostatin is useful or not? Just for the sake of the to clear it off, how it came in a big way, the people started trying that. Now, what is the current status?
I don't think we have enough data to recommend it.
Okay, number one. Now, initially, the image-guided culture study to differentiate SARS versus sepsis was recommended. Now, most of the center. So, what is your current concept about image-guided, the needle, and take the culture for study or gram staining? Will it be useful, or are we practicing, or is abandoned?
Yeah, so this I referred to this in my talk too as well. I think that there are some gaps. I think it was intended to be best practice to guide your antibiotic therapy based on the aseptically acquired fluid collection cultures. Don't know how consistently it is done. I think one thing that has happened. Every new technology and paradigm has a pro and con side, right? So once EUS guided drainage became so easy, especially in the LAMS era, I dare say the vast majority of these patients are going downstairs and just getting their collections drained. I think the concept of percutaneous drainage is a little bit less used, except in those situations, I suspect, where the EUS access is difficult, such as paracolic areas or other deep retroperitoneal areas. So, but I would support it any day. I think that in a patient that is a conundrum in terms of where the infection might be coming from, and you have a collection and you have access to it from IR, I would go for it.
But that can introduce infection, no, Vivek? So that is
Yeah, but from
why.
Yeah, it can, but as I said, if the access point is relatively straightforward and you're not going through bowel or other viscera, aseptically acquired culture is probably better than blind antibiotics in a difficult case.
I don't think any Indian centers are doing this kind of the needle guided the culture study or gram staining.
Yeah, I don't think anybody's doing it very consistently.
Pramod, there is a question from one of the delegates in acute necrotizing pancreatitis with the AK and anuria. How do you plan your therapy and fluid therapy?
So I think very important point. So in the beginning, within the first 24, 48 hours, someone can have oliguria because of hypovolemia. So initially, if you feel that patient is hypovolemic, we need to give fluids. But beyond a certain point, once you see that you have given, say, a liter of fluid and a liter and a half over 8 hours or 12 hours, and there is no increase in urine output, you got to be a little careful. So for the first 24 hours, you can give about 2.5, 3 liters of fluid, but if you find that the urine output is not improving, stop giving more fluids. That's very important.
You suggest fluid challenge.
Yes, that's about it. And so checkpoints are very important. When you say, I give 3 liters of fluid in 24 hours, doesn't mean that I give orders in the morning and forget till next day morning. No. Every 8 hours, there are checkpoints, and you have to monitor these patients very carefully in the ICU.
So fluid challenge and very watchful, and no improvement, then it is there. Chaubal, you want to say something?
I just wanted to ask, how do you look for and how do you diagnose in your clinical setup the abdominal compartment syndrome? Is it by the urinary catheterization and measuring the pressure? How do you handle these situations?
So clinically, if you find the abdomen is tense or there is guarding rigidity, and many times you find that, you suspect it. But most patients who have got moderate to severe pancreatitis are catheterized, at least those with organ dysfunction, and then you measure through the urinary bladder pressure. That's the routine in our practice. Those who have severe.
Yeah, that is the one. Any role for prophylactic anticoagulation, acute severe pancreatitis, low molecular? You refer to some study, but now what is the guideline?
So as of today, there is none. The only thing is that you can give prophylactic low molecular weight heparin as you do in any ICU patient, regardless of the underlying disease. So someone who is going to be in ICU on a bed for days and weeks, there is no harm in giving prophylactic heparin, right? The question is there a role for therapeutic heparin here? And I showed you there are some trials ongoing, and there is actually a meta-analysis which was recently published which showed that therapeutic low molecular weight heparin might decrease complications of acute pancreatitis. So we need more data on that.
One interesting question from one of the delegates is, what are the unmet needs right now in acute pancreatitis? So what do you suggest me to go for kind of research in acute pancreatitis? Both of you can take up this question. So that a lot of delegates are watching, they want to take
This
up
was
some-
exactly what I was hoping the discussion will go to. I think, as I pointed out in my talk, I think pain management remains a big unmet gap. I think our understanding as a specialty of how important pain is, the fifth vital sign, at least in this country, it's a huge contributor to debility, to length of stay, to patient wellness, and I think we have not paid enough because we are caught up in obviously a very important situation with the systemic SIRS and the complications from the pancreatitis itself. I think pain is something we need to pay more attention to. I mentioned that nutrition remains a challenge, even though there is best guidance that we don't really have a low threshold for restarting enteral feeding, sometimes for good reason, but many times even when we can, we are not doing it. TPN is so easy, but it's so catastrophic if you use it long term. So for me, these are two big ones. I know Pramod has a couple good ones in the first week that he already referred to.
Yeah, my only thing is
what is your take?
targeted therapy.
Right.
What is your research potential?
We need targeted therapy.
Targeted. That's you already pointed out. That means what are the areas? Suppose this kind of small molecule getting released, and these are the things that will be a good thing for most of the diseases, more so in acute pancreatitis. Devendra, you asked about the IVC diameter. Already he covered it, and Dr. Pramod that. So clinically is a very, very useful thing. In fact, residents can do that ultrasound guided IVC. Any questions?
Dr. TSC, even though it was not my topic today, but I think that if you ask me, one of the things, whether it's research or whether it's practice-oriented innovation, is that the first 12 hours, really kind of have some national guidance on that. In the first 12 hours, what happens to these patients? Their pathway through the emergency room needs to be algorithmized, and they need to be moved along the fluid, algorithm much faster than we are currently doing. That I think is a big area that we can focus on, and that will help a lot of patients who are currently just in the first 24 hours, just lounging somewhere, third spacing, cytokining, and just going very fast towards organ failure. These could be salvageable patients. I think that's a big area that the next generation will need to focus on as they lead these units, they lead the hospitals, they're in charge of emergency room guidance. I think that's a big area we need to focus on. The door to fluid time.
Thank you. Another interesting question. Same topic you are discussing after 10 years. What will be your thing would have changed? Pramod and Dr. Vivek Kaul.
My feeling is that we will have at least one solid therapy which will be targeting the systemic inflammation in these patients. That's what my hope is, and I think we should
get a message is targeting many times the targeted therapy. So that is the thing we should take a guideline from you, that since you have been working on this field almost 2-3 decades since I know you. And Vivek, what will be your talk?
I think gallbladders will be removed at birth, and alcohol will be wiped off all the shelves. No, I think that we will be more sophisticated in our critical care management of, I'm talking to the 2nd to 6th week. I think more multidisciplinary care will need to come in, or will likely come in. These patients will receive better care from teams that are specialized in this space.
Okay.
And these are the kind of discussions that inform that type of future strategy. But hopefully fewer patients will come to my part of the lecture than they come today. So Pramod's vision will probably come true.
Praveer, you are one youngest of the faculty now. What would be 10 years later? What would be your take?
Yeah, so I think Dr. Pramod has already mentioned that. I think that's the
Targeted
right now
therapy.
what we are struggling is any specific therapy for pancreatitis. So that's the problem. So I think that's very important. That's for what we need an answer.
Any quick question from ambassadors who are watching that? Vivek, you want to ask some question, or Arvind, or Devendra and Sahin? Any question from there? Before we move on to the very lighter session, we are going to have that ended to know more about the faculty. Any questions from, yes?
Yeah.
Yeah, one question
Any
before we
long-term
ask.
follow-up, maybe 10, 20 years after severe acute pancreatitis, is there any data that how many of those will end up in chronic pancreatitis?
So yes, there are many studies actually, and overall about a third of patients might develop recurrent acute pancreatitis, and about 10 to 20%, depending on the series, will develop chronic pancreatitis during follow-up. Particularly the patients who have alcohol-related pancreatitis and those who have underlying genetic mutations. So one third will
Yes.
have recurrent acute, and about 10 to 20% will develop chronic pancreatitis.
I think it's,
And especially-
I remember I referred to your own work. You had a nice presentation about what you initially diagnosed acute, the recurrent pancreatitis. Almost 60% go into the chronic. I remember that one of the meetings you presented. That's a great work you have done. I appreciate that. My colleague Dr. Satya wants to ask question. There is a small interruption. Okay.
Hi, sir. Yes, in many situations, we find pancreatitis with no known etiology. We find a distended gallbladder with a sludge alone. Will we still call it as a biliary pancreatitis, and we want to intervene with the ERCP procedures?
On laptop.
And do you recommend laparoscopic cholecystectomy in these patients?
That's
So this is a controversial topic, but there is data against it, but there's also some expert guidance towards it. I think if you have sludge in a gallbladder in a young, healthy, surgically fit patient who had an index episode and nothing else is found, I think it's not unreasonable to consider that. But the vast majority of these patients are being referred for cholecystectomy even when they have no sludge and no microlithiasis, no stones, and that's where the real controversy comes. Genetic testing is not used as often as it should be, but that's another area of unmet need. What are you going to do with it? I'm not sure, but at least there's closure of the loop that you don't keep investigating that patient for other things or subject them to unnecessary invasion. So I think that's the value of genetic testing. Sorry.
Pramod?
But I tell you, the guidance here is the liver function test within the first 48 hours. If you have a patient whose LFT is abnormal, your SGPT is more than 150, your LFOS is up, and or your bilirubin is up, it is likely to be biliary, regardless of what you find in imaging. But if your LFT is normal, even if you have stones demonstrated in ultrasound, it's very unlikely that it is gallstone-induced pancreatitis. And this happens in patients, so those who are alcoholics and also have stones. How do you differentiate which cause pancreatitis? Because 90% of alcoholics do not have pancreatitis, and LFT is the way to go.
Okay.
Yeah,
Now we have come to the last 10 minutes. We want to restrict to the.
I have a question.
Sorry, we can't take up more question. And this is the work while you work, play while you play. Then that's the thing. I thought we will have some lighter session. Now only the all four faculty, Pramod and the Vivek Kaul and Praveen Roy and Chaubal. If not, you are now. If not a doctor, what you would have become, Pramod?
I don't know. I think I always wanted to become a doctor, but
Wanted to become a doctor. Okay, Vivek Kaul.
I wanted to be in advertising, but my father said that's not possible.
Okay,
So-
right. And Praveen Roy.
Always wanted to be a doctor, but if not, then maybe in movies.
Movie. I guessed it. Okay, Chaubal. You also want to be in movie.
no. I had a passion for becoming a doctor right since beginning because my grandfather, that means from the maternal side,
Very brief
he was a
answer. You have
doctor.
10 questions. And your grandfather a doctor, you want to become a doctor. But the way you're sporting with emotion, other thing, I thought you will be an actor.
But we are also in music and everything. A lot
How
of
did
things
you
are there.
develop interest in pancreatology, Pramod? Quick answer.
you said, how did I?
Develop interest in pancreatology.
I think it is the patients that we were seeing that we were not able to do anything for them. And that's what, challenges you.
Oh,
So
the challenge made you think.
also a
Vivek,
challenge, yes.
Yeah, so I had a personal connection with pancreas cancer, but also I feel the same way as Pramod. I think I
okay, the
regularly
challenge
speak to
made you. And
challenge, but
Ravi,
also personal connection, but also I feel like infection, bleeding, and perforation we have control.
sorry, I'm interpreting
Yeah,
or
all good.
hearing. I just want a very brief answer. Challenge
Brief
is the
answer.
answer for you. And Pravir Roy,
Yeah, a lot of patience and many interventions.
intervention is possible. How do you get time for research and publication, Pramod? You must tell the secret.
I wish there were more than 24 hours in a day.
Okay, you wished and you will have more, but right now you are doing a lot of publication. How do you find time, or what is your mantra?
Keep working.
Keep working, Vivek.
Yeah, same here. Busy person has time for everything. That's why he or she is
The
busy.
busy person is the one who finds time for. Now the question is, what is the turning point? When did you appreciate there's a turning point in your career? After joining AIMS
Pramod,
or something like
Pramod,
that, what turning
So-
point in
Pramod.
your career?
So turning point is, when you want to become a researcher from a clinician, that's the turning point. And that points come somewhere 3, 4, 5 years down the line. You realize you really don't know anything.
Okay.
Initially,
So
you were
want to
thinking you
become
know
a
everything.
clinician to researcher. What about Vivek?
Yes.
For me, I have to say that my year with Joe Geenan and his team in Milwaukee was
Okay, you found a
transformational.
mentor, you became like that.
Well, the whole team there. I mean, we had 9 people doing complex pancreas work, and
Okay, now
that,
you met your mentor, the turning point. What about Pravir?
Yet to come.
Yet to come. That is a very good answer. Very good answer. I liked it. That keeps moving that. And what is the ideal path for a future clinician? Pramod? Now,
Ideal?
path for a future clinician.
No, I think it depends which setting you are in. If you're in academic, for sure, you have to be, going the physician scientist way. But if you're in practice, I would say even in practice, you can contribute much more to science.
Okay, right.
So, and
Right.
there are many people in this country who have shown that.
So, what is your mantra for work-life balance? I should ask your spouse.
So, a friend of mine, Ashbourne Drews, you must have known, he's in Denmark. He said that people talk about quality life, quality time with family, this and that. He said this is all nonsense. If you work well, your family appreciates that very well. Your children appreciate that. So surely you must spend time with them. But, just to say quality time family doesn't mean that, you have 8 hours.
Always hanging around there and create more dispute.
Not for doctors, by the way.
Not for dogs. So your work is such a way that you put it across, they appreciate. Vivek, your take is?
Yeah, so in terms of ideal pathway, there's no such thing as an ideal pathway. I think best practice and patient-centered care is the ideal pathway. Okay. Second point, work-life balance. I'm able to compartmentalize relatively easily, but these are not competing priorities. I think we enjoy what we do. We enjoy our families. We enjoy our work. Never been a problem, I don't think, so far.
No. Pravir, you're too young to discuss about it.
Pravi is looking good.
And Chawbal? You're too old to discuss about that.
No. But we have a good work-life balance. Everything is there. We do everything.
Okay. The next question is, how do
Balance is
you
the key word.
de-stress?
Very strong social circle, everything is there.
You have a good social circle.
Social circle, enough of this thing. The whole day we keep working. 1 hour I devote daily for reading in the morning. Then subsequently exercise. Then the whole day we work. Evenings we have a lot of parties, music and everything. We have so many musical kitties and everything. So many things are there.
Okay, I have to be very careful because my son is watching here. So he will tell me how much work I did. Vivek Sandeep is there. He's working in USA as a gastroenterologist. And he will tell me how much I contributed for it. Okay, now the question is, how do you de-stress yourself?
I think the biggest stress comes when you're not able to finish your work. So if you finish your work, that's the best de-stressor.
Okay.
And then I would say then pick up a book and that's the best thing.
Okay. What is the last book you read apart from pancreatology?
So no, I don't read pancreatology, by the way.
Any good book that you have read you want to suggest right now?
Yeah, so I would, if you want me to suggest something, read Black Swan. It is a difficult read, but it's an excellent book.
Okay.
Black Swan is the one by Nicholas.
Okay, thank you. How do you de-stress, Vivek, call?
For me, it's cooking and music.
Cooking and music.
Yes.
So I have a host there in USA when I come there.
Anytime, sir, especially now
So
with summer
cooking, huh?
starting.
Very
You're all
good.
welcome.
Praveen, how
So
do you
it's,
de-stress?
yeah, so it's running, music, and dance.
Dancing. I thought you will eat what you cook. And Chaubal, you have various avenues to de-stress for you, no? And then,
No, plenty.
okay. Who is your favorite cricketer?
Mine,
Pramod? Ah.
mine is Kapil Dev, and earlier was G.R. Vishnath.
Oh, you are telling your age now.
Of course.
Okay. And Vivek, you watch cricket?
So for me, it really doesn't get better than Waqar Yunus and Wasim Akram. I mean, to me, they were the best
Yakub
of the
man, huh?
best.
Wasim
Yeah.
Akram, huh? You
I
were
mean, the two
impressed
of
with
them. The two of them, they had about 3
who
years
is
in
the other one
common.
you said? Wasim Akram and?
Wasim Akram and Waqar Yunus. When they were on both ends, nobody had a chance.
Nobody had a chance. What about Pravir Roy?
Dhoni.
Dhoni and Chaubal, you himself cricketer, I know that.
Yes, I think I certainly would place it for Bumrah because I have opened from my college for at least 7-8 years. One end I used to open bowling.
Okay, you like Bumrah. Okay. What is the non-medical book? He already told. What the non-medical book you read? Chaubal, Vivek Kaul and Pravir Roy. Okay, maybe next meeting you tell us.
I don't.
Okay.
I'm not a good
What
book
are
reader.
your
I've read all.
hobbies? No? Who is your favorite Hollywood and Bollywood actor?
Me,
Pramod, yeah.
I mean,
Uh,
Amitabh Bachchan and Dilip Kumar.
Dilip Kumar. And Hollywood?
Hollywood, I think Tom Cruise is good.
You come to the
But
very
if I
recent
tell you a
Tom
secret,
Cruise.
don't laugh at me. I used to like in my days Bo Derek. I don't know whether you have seen her movies.
Yeah,
We all
number
love Bo
10.
Derek.
Number 10, huh? Number 10. Okay, what about number 10? I know that, Bo Derek. And what about, I'm not laughing, I'm appreciating that. You appreciate the nature. Okay, Vivek.
Amitabh, of course, but on this side, Robert De Niro, I think,
Who's the other
really
one?
amazing. Robert De Niro and Amitabh.
Okay. Pravir Roy, you said you were dancing and other
So
thing.
Tom Cruise and Amir Khan.
And Amir Khan. Okay, PK and other movies, huh? Okay, Chaubal, you have a long list. I think you said one.
Gregory Peck on that side.
Huh?
And as far as this Amitabh Bachchan and certainly Gregory Peck on the other side, on Hollywood side.
Okay, now the question to all of you, what is the famous quotation you like? Pramod, Vivek, and what is the famous quotation?
So I tell you one related to medicine, the other is non-medicine.
Okay,
for
whatever
medicine-
maybe.
So for medicine, if you have a pain in the abdomen, think of chest. If you have a chest pain, think of abdomen. And in either case, think of the spine. Okay. I like that and I follow it.
Okay, right. Then?
And the non-medical one is my own. Don't be a prisoner of your own ambition.
Okay, Vivek Kaul. What is the non-medical one you said?
Don't be a prisoner of your own ambition.
Okay. And that is coming from Pramod, huh? That is fantastic. Don't be a prisoner of your own ambition. All these questions have not been leaked. Just I'm asking. Okay, Vivek.
It's true. Oh, so medical wise, I many times I've seen this people
No,
fail.
only one quotation because
Yeah,
time
one
is
quotation.
running out. We have only 1 minute now.
When you tell the professor I've examined the patient, make sure you have lifted the sheet and made sure there's no amputation.
Okay, right. Pravir, your quotation is?
So train insane or remain the same.
Okay, right. And Chaubal,
right.
your quotation is?
I don't remember. There are so many quotes.
Okay, so many. Now we are going to have in September the Nobel Prize winner from clinical medicine, James Barry Marshall. Barry James Marshall, sorry. And what is the path for a clinician to get Nobel Prize in medicine? Pramod?
Matter of chance and luck.
Okay, luck and?
Hard work. Without hard work, you can't even dream.
Hard work and pray for some luck. Huh?
But I tell you something, very important point. I met a Nobel laureate once, not from medicine, otherwise, and he gave a lecture outside of his area of Nobel, for which he got Nobel. And later during dinner time, I asked him, why are you working so hard? You already got the Nobel. You know what did he say? I never worked for the Nobel.
I never?
Worked for the Nobel.
Work for work. Okay. Vivek?
I agree with him 100%. I think serendipity, as Barry will tell you himself in September,
Yeah, he's
serendipity
going
is
to
a
tell
big
us
part of these.
serendipity also there.
Big
But
part, big part.
he has to work hard, then the serendipity will come. I know serendipity like Alexander Fleming and Barry Marshall, and there's so many things I know about that. I was fascinated by those stories. That's the reason I was very particular to have one novel already in our webinar series. And I did a time for to wind up with a vote of thanks. Sorry, I'm not able to ask more question. I think hope all you guys enjoyed both academic and the lighter friend, and fantastic both the lectures and the moderation and of all and the ambassadors and delegates. I thank you very much. We'll meet next month. Before that, I will hand over the mic for 1 minute. The most important thing is to thank you from my colleague Satyamurthy is going to tell about that.
But I must say that I have enjoyed this webinar more than I have enjoyed any other talks. A fantastic webinar series. Thank you.
Means a lot, Pramod, coming from you. And same here. I express the same sentiment. Amazing.
You want to say something?
Yes, sir. Dr. Pramod, sir, you want to tell something, sir? Nothing. Yes, good evening to one and all. It was indeed a wonderful and inspiring session that we all enjoyed today. And on behalf of Medindia Hospital and the organizing team, it is my pleasant task to propose the vote of thanks and conclude this webinar. At the outset, I would like to thank my chief and Professor Dr. T.S. Chandrasekhar sir, the organizing chairman, and the brainchild of this interesting international webinar series for excellently drafting this program and for bringing together the world-renowned gastroenterologists as the speakers and chairpersons, and also for getting accreditation from the American College of Gastroenterology. Our sincere and heartfelt gratitude to Professor Dr. Pramod Garg sir for your excellent lecture on the management of the acute severe pancreatitis during the first week. And your presentation was truly outstanding. And very thank you, sir, for sharing your insights and wisdom regarding the targeted therapies, which we will focus later on. So we are delighted to have with us Professor Dr. Vivek Kaul to share his expertise in the management of the acute severe pancreatitis from 2nd week to 6th week. Your presentation was genuinely unremarkable, sir. And thank you for your informative and lucid presentation. It was indeed a privilege to have among us Professor Chaubal sir and Professor Dr. Pravi Rai sir as moderators for today's sessions. And we appreciate both of your insightful comments and for the lively interactions. And our sincere thanks to all our national and international ambassadors who are constantly being in contact with us and work very hard for their excellent support and bringing more attendees for this webinar. I must also thank my colleagues and friends here at Medindia Hospitals, Dr. Prasad, Dr. Gokul, Dr. Raj Yogesh for their support and encouragement. And a big thanks to our technical support team, Mr. Sashidran, Mr. Shiva, Sasikala, and Selvi for their impeccable arrangements and logistic support. I must thank our academic partners and the sponsors, the Michaelas Pharmaceuticals, Mr. Jairaj sir, Mr. Subhendra Kumar Datta, and Mr. Padmanabhan and his team for their relentless and educational grant and support. And of course, we extend our wholehearted gratitude to the online delegates for their lively participation and hope you have enjoyed this webinar as much as we did. And we are glad to invite you for our forthcoming webinars, which we scheduled for next month with some exciting topics. Till then, wishing all a good health and goodbye.
Thank you.
Thank you.